I can just say a quick hello. My name is Meg Chappell, and I'm the program manager for Empire Liver Foundation. And we want to just thank you for having us today. And before Dr. Kalia gets started with his webinar on the clinical management of hepatitis B, we have Christina Wang with us, who's a surveillance analyst for the viral hepatitis program at the New York City Health Department. And she's just going to share some specific data related to Sinai regarding hepatitis B. So I think, Dr. Kalia, if you can click through the slides, and Christina, you can just introduce yourself and walk us through those slides.
Hi, everyone. My name is Christina, and I'm a surveillance analyst with the Viral Hep program, like Meg said. In anticipation of today's grand rounds, the Viral Hep team has created a short presentation on some metrics that we've developed to measure the quality of Hep B and C care being delivered to New York City residents. It looks like today, sorry about that. These indicators can be used to monitor care, identify trends, and track progress towards Hep B and C elimination. So next slide, please. So we'll start off with Hep B. We have 3 indicators for Hep B, which include volume, viral load assessment, and monitoring of newly diagnosed and chronically infected patients. Just so you know, to create these indicators, the health department uses any lab reports that were ordered by Mount Sinai Hospital or Mount Sinai Morningside. And we do receive all positive Hep B surface antigen, positive E antigen, positive and negative DNA tests, and genotype tests. So moving on to the first indicator. Perfect. So the data presented in the following slides are a snapshot in time over most of 2021. So from October 2020 through September 2021. This first indicator here is volume of patients with chronic Hep B. And this metric measures the number of people infected with Hep B who are seeking or are currently in carrier facilities. So we determined this volume by the number of people who had a positive surface antigen, positive E antigen, positive DNA, or negative DNA. So within this time frame, Mount Sinai Hospital saw 757 unique patients, and Mount Sinai Morningside saw 166 unique patients that met these criteria. Next slide, please. The second indicator is viral load assessment, which was created because we want to know if surface antigen positive patients are being assessed for treatment initiation. This indicator looks at patients who tested surface antigen positive at your facility and what percentage were brought back for a follow-up DNA test within 6 months. In the past year, 227 patients were surface antigen positive at Mount Sinai, of which 40% had a follow-up DNA test within 6 months. And at Mount Sinai Morningside, 46 patients were surface antigen positive and 74% had a follow-up DNA test within 6 months. Next slide, please. The last Hep B indicator is monitoring. And from this indicator, we pretty much want to know if facilities were performing viral load tests periodically. For newly diagnosed patients, which is shown on this slide, this means having a second DNA test within 6 months of their first positive DNA test at your facility. Patients are considered newly diagnosed if they had their first positive surge antigen, E antigen, or DNA test ever reported to the health department within that year. So over the past year, Mount Sinai Hospital and Mount Sinai Morningside had 18% and 44% respectively of newly diagnosed patients coming back for a DNA test within 6 months. Just something to keep in mind, we only looked at tests ordered by your specific hospital. So a lower percentage may reflect your hospital's practices, such as referral to an outside program or health center. Next slide, please. So continuing on with monitoring of chronically infected patients, patients are considered chronically infected if they ever had their first positive surface antigen, E antigen, or positive DNA ever reported to the health department before the year in question. For chronically infected patients, we want to know how many patients had a DNA test within 18 months of their last DNA test. Again, this data only includes labs ordered specifically from Mount Sinai Hospital or Mount Sinai Morningside. And at Mount Sinai Hospital, there were 197 patients who had a DNA test in the past year. Of those, 47% had a previous DNA test ordered within 18 months prior. And at Mount Sinai Morningside, there were 75 patients who had a DNA test in the past year. Of those, 63% had a DNA test within 18 months prior. Next slide, please. So just moving on to Hep C indicators. Similar to Hep B, the first indicator for Hep C is volume of patients. The volume of patients is determined by number of people who had a positive Hep C antibody, RNA, or genotype test ordered. So in the past year, Mount Sinai Hospital saw 494 patients who tested Hep C positive. And at Mount Sinai Morningside, there were 241 patients who met this criteria. Next slide, please. Now, the second Hep C indicator is RNA confirmation rates or reflex rate. Reflex RNA testing just means that a laboratory will automatically perform Hep C RNA test if the result of a Hep C antibody test is positive. We consider RNA test to be reflex if the RNA test has the same specimen collection date or specimen number as a positive antibody test. So the health department's goal is 85% citywide. Mount Sinai Morningside is a little bit higher than that at 94%, and Mount Sinai Hospital is a bit lower at around 62%. And that's data from the last year. Next slide, please. Lastly, the final Hep C indicator is treatment initiation rate. And from this indicator, we want to know if patients who are diagnosed with Hep C are receiving treatment based on DNA testing trends. This means having a negative RNA test within 6 months of their last RNA test. Something to note here is that this metric is based only on lab data, so it may include people who spontaneously cleared their infection as well. In the past year, there were 128 patients who tested RNA positive at Mount Sinai. Of those, 12% tested RNA negative at Mount Sinai within 6 months. And at Mount Sinai Morningside, there were 89 patients who tested RNA positive. Of those, 18% tested RNA negative within 6 months. Next slide, please. So this data is the same as the previous slide, except we looked at negative RNA tests ordered from any facility, not just Mount Sinai Hospital, Mount Sinai Morningside. So you can see here that the treatment initiation rate has increased for both sites. 33% of patients who last tested RNA positive at Mount Sinai had an RNA negative test from any New York City facility within 6 months. And at Mount Sinai Morningside, 21% of patients had an RNA negative within 6 months as well. So this concludes the health department's portion of the presentation. If anyone has any questions, they can just put it in the chat, or I'll stick around towards the end. Thank you.
Thank you. Yeah, Dr. Clay, you can just jump in. I think we kind of explained Empire Liver Foundation and the health department. Empire Liver Foundation is a group of New York City liver specialists, and we're dedicated to increasing community awareness of liver disease. We provide education to providers like yourself. We offer CMEs through grand rounds. We offer mentorship and preceptorships and clinical training series. So Dr. Clea, you can take it over.
Good afternoon, everybody. Can everybody hear me well? Thumbs up if you can. I know you can't see me. Thanks for coming this afternoon. This is an important topic. And just to sort of reiterate what the Empire Liver Foundation does, I think it's there are not a lot of cities in the world where a group of experts come together, and with the help and dedication of the Department of Health, has a good collaboration in making sure that New Yorkers get the best care possible. And with data is the only way they can do that. So I think they spend a lot of time and effort in collecting data, which certainly helps us track progress. And with these learning initiatives, it certainly gives us a certain benchmark to improve upon, all of us collectively. Anyway, the learning objectives today are listed. Basically, we're going to try to go, describe the whole hepatitis B situation, and then talk a little bit about the different aspects of the natural history, where vaccination has made an impact. Certainly, since you guys are interns and residents, talk about the hepatitis B serologies, because They're going to keep coming up at clinically and on exams. So it's important to sort of just pin that down really well. And what kind of education you want to provide to your patients regarding preventing hepatitis B transmission, and a couple of things about pregnancy. And so we'll try to get through all of this in the next, hopefully, 40 minutes. So first on the epidemiology, we always look at this slide about, and the colors on the slide keep changing over the years. So the hotspots for hepatitis B globally are in West Africa. And if you looked at this similar slide from a few years ago, there was more red in Asia as well. And everything has to do with how hepatitis B is being addressed at each country level. Meaning, is there a global health policy of initiating vaccination at birth? And if you compare parts of Africa and Asia to North and South America, or at least North America, you could see that the prevalence of hepatitis B is quite low in North America. That doesn't mean we don't have to deal with it, because as you know, even though there are about 300 million people across the world with this ailment, which is devastating for many people because it's often diagnosed late, many people are immigrating into different parts of the world, especially North America. So the disease, unfortunately, follows the patient, and it changes the landscape of cities across the United States. So it's something that we're going to have to deal with. We can't just say this is a sub-Saharan African or Asian issue. So this is I always call this a report card, which is all the way to the left is the number of chronic hepatitis B infections in the country. Obviously, it's an estimate. There's a low and high estimate, but so if you sort of calculate that there are approximately about 2 million people potentially who have hepatitis B in the United States, how many are aware? About 400 to 600,000. How many are eligible for treatment? A little less than the number I just mentioned. And then how many are actually linked to care? 200,000. And then how many actual prescriptions are written is 50,000. So this is not a very good scenario where, and again, some of this was alluded to of what Christina was saying earlier, which is when they track numbers, great, you made the diagnosis, but are the patients being linked to care? And are they getting the appropriate care, whether it's liver cancer screening or treatment or both, or appropriate monitoring? So it's important to note that this is a chronic illness, and it's not just a one-time visit. These patients are going to need appropriate follow-up. So there's a lot of gaps in the hepatitis B care in the United States. And as I mentioned earlier, a good number of these patients will present at a very late stage, either with cirrhosis or HCC or liver failure. And really by that time, it's really too late to do anything, including transplant. We often have to just call palliative care to have the serious discussion of why a 28-year-old patient from Africa who's working care for the last few years but didn't see a doctor or even knew that they had hepatitis B now has to die. And that just shouldn't happen on our watch. And equally important, besides just taking care of or identifying patients who have hepatitis B by raising awareness, it's equally important, if not more, to make sure that there's appropriate vaccination strategies at the community level. Every time you see a patient and you get a sense of their origin, and as an adult, I'll change the discussion later on, but so far, I mean, 25% of US adults have been completely vaccinated because the vaccination strategy in the United States started in the mid-80s. So anybody born after that in the United States has been vaccinated at birth or starting at birth. But there are a lot of adults who were born before that, obviously, have not been vaccinated unless you're in the healthcare field or for other different reasons. But certainly the recommendation of making sure that adults are also vaccinated recently changed. So this is something that we have to pay attention to based on their risk factors in terms of identifying hepatitis B. So I'm going to just skip over some of these slides because I know I'm going to run out of time. But basically, the bottom line here is essentially what I had mentioned earlier on the United States scale. But this is basically saying that if there are about 100,000 people who are reported to have hepatitis B in the last few years, only half of them are aware of their status. So it's really important to, depending where your clinics are and the patient population, that you make sure that besides a million other things that you have to do to help these patients, you also are thinking and then testing for hepatitis B, because it's really a brutal, silent disease until it's too late. We often, the chart, I'm sorry, the slide that I showed you with the world map, it sort of translates into this slide in terms of numbers, where the hepatitis B infection in the foreign-born population, they're about 14%. So foreign-born persons comprise 14% of the U.S. population, but 60 to 90% of the people living with chronic hepatitis B. So some of the places that we often think about are listed here where those high-risk areas are. So again, a bell should go in your, go off in your head about, okay, this patient is from West Africa, or this patient is from certain parts of Asia. I have to ask them about hepatitis B. I have to ask the family history of hepatitis B. And then if they are totally unaware of whether they've been checked or not, I should check them for hepatitis B. And if they're negative, I should vaccinate them, at least tell and have them make sure that they get their families checked. Going back to New York City data, some of the hotspots of hepatitis B are again in these dark blue areas. And essentially they're parts of Brooklyn, parts of Queens. Again, these are concentration of, in certain communities where there's a high immigration patterns from the areas globally. So what's not listed here is parts of the Bronx. That data is, I think, still being collected, but there's a high concentration of people from sub-Saharan South Africa that are that live in parts of the Bronx. And I think as we get more data, we'll be able to highlight that that's another pocket of high concentration for hepatitis B. But again, knowing the neighborhood where the high concentration of disease is helps the Department of Health and the physicians in the community strategize their resources and help these patients. Hep B infected pregnant women in NYC region of birth, again, not a surprise that the high concentration is for patients from China and of course West Africa and other areas are listed. The natural history is important to understand, but we'll start with how sneaky this virus is. So we've all seen this studying from step 1, step 2, and of course, I tell you, this is always going to be on an exam, not necessarily the structure, but different aspects of hepatitis B. But the blood test where we look for the actual infection is the surface antigen. That's these, the outer surface of the virus. And then, of course, then there is the core antigen, which is on the inner side. The DNA is on the center of the virus, and then the E antigen is surrounding that. So, what do all these things mean? Well, the surface antigen, basically, the presence of it greater than 6 months, basically is the definition of chronic hepatitis B. So that's what we check for when we do the blood test for when we screen patients or diagnose patients for hepatitis B. The E antigen is a marker for how quickly the virus is replicating. So if the E antigen is positive, the likelihood of the virus load, the viral load in the blood is going to be high. Now, there's a second form of that would be if the E antigen is absent and the E antibody is present, and I'm simplifying here, then the virus count should be lower and not in the millions and billions, usually in the thousands. And then the core antigen is something that we can't detect in the blood, but we do have a marker for the core antibody. And again, if the IgG is positive, and I tell you this was on my board exam for internal medicine, that acute hepatitis B diagnosis, what you're looking for is the core IgM. Because IgG infers a chronic or prior exposure, but IgM is what basically separates acute from chronic. So when we have access to these blood tests, which is the surface antigen, the E antigen, the DNA, how often should we be checking them? Again, going back to what I said earlier, is that this is a chronic illness. This is somebody who, if doesn't meet criteria for treatment, you want to monitor them enough times over the course of the year and moving forward, so that when it is appropriately, if they're followed appropriately, you will hopefully catch them in that window where their liver test or their viral load is at that point where you can then consider them for treatment. So we're on a regular basis checking them for the surface antigen, because some of them also seroconvert, the E antigen, because sometimes they seroconvert from the antigen to the antibody. You want to know what the virus count is, and also in the context of what their liver tests are doing, the AST/ALT. What is the role of the liver biopsy? Well, we used to do liver biopsies a lot frequently in patients, but we now do it selectively in some patients who we maybe can perplexed by their liver tests and their viral load. So we often use fibroscan, which is elastography, to determine if they have advanced fibrosis or not, and then consider them for treatment. So I mentioned earlier that this is a brutal disease because it can, if you get the acute infection, it can turn into chronic, especially depending on what age you get the infection at. The older you are, and if you have icteric illness with the acute infection, the likelihood of clearing the virus is higher, as opposed to those who get infected through maternal fetal transmission. Those patients, 100% of the time, get chronic infection. And once you do develop the infection, chronic infection, there's just all ugly pathways that it can follow, either road to HCC, cirrhosis, and then that sort of further leads to for transplantation. Of course, the mortality is high. I often say this to liver fellows, GI fellows in clinic, that the hepatitis B virus not only has a fibrogenic potential, meaning cause advanced liver disease to fibrosis, but it also has oncogenic potential, meaning it increases your risk for liver cancer without even the presence of advanced fibrosis. What really taught us a lot about hepatitis B was a natural history study called the REVEAL study, done in Taiwan a few years ago. And basically, they had thousands of subjects that they followed without them being on any medication. This was a long study. It was over a decade. And they basically followed patients with surface antigen positive. They had a lot of data. They had surface antigen, they had viral loads, they had what the outcomes were. And basically, the punchline of the study was several observations. One, if you're surface antigen positive comparing to surface antigen negative, that's going to impact your survival. So people with surface antigen positive are going to have a lower survival. Then they further looked at what does the level of the viral load determine, how does that determine your survival? The higher the viral load, the worse your survival. So this information has always gone into the development of the guidelines where we actually look at the viral load along with what's happening at the liver in terms of liver tests or biopsy information to determine if someone needs to be treated. So the other thing that was looked at is progression to HCC. And again, clearly the presence of a higher viral load clearly impacts the risk for cancer development. So when we are considering treatment for somebody with chronic hepatitis B, yes, you can look at the viral load and certainly follow the guidelines in terms of the viral load. Sorry, my phone is ringing in. We'll figure it out. So looking at the viral load and the liver test is important in terms of determining the need for treatment, but also family history of liver cancer and reducing their risk for liver cancer is also important. So these are some of the things this study has taught us. Prevention. So again, I can overly simplify it because it's that simple. Vaccines work. Certainly in the context of hepatitis B, vaccines work a lot. So when we look at infants, again, for the nations that have hepatitis B vaccination policy, public health policy, then it's a wonderful thing. We've all gotten it if you're born in this country or a country where you where the policy exists. And if you weren't born in a country like that, then and before entering the medical profession, you have to do it. Either way, hopefully we're all protected with this vaccine. And again, there's several vaccines on the market. This is not a talk for that. But again, vaccination works, especially when you started at infancy. The CDC recently basically recommended that adults from age 19 to 59 also should be vaccinated. There's another slide that's coming up, and I'll go into that in a little bit more detail. But we used to think that the people, adults who need vaccination are on this list, people with risk by sexual exposure or by risk by percutaneous or mucosal exposure. And that's how we used to sort of strategize which adults need Hep B vaccination. Also, as a hepatologist, people who have one form of liver disease, let's say fatty liver disease or hepatitis C, those are patients who would not do well if they got acute hepatitis B. So that's another category of patients that we would vaccinate for hepatitis B. And again, some of the other people, sort of high-risk adults are listed here. But then the CDC looked at a lot of data and basically noted that the acute Hep B cases that occurred recently, majority of those people were age 30 or plus. And these patients are the ones who typically have a low likelihood of being vaccinated um, when they were younger. So to sort of really reduce and eliminate their risk and not get into this that, well, who's high risk and who's low risk for hepatitis B, um, putting all this data together, their recent recommendation was that this group, this cohort should also be vaccinated. And I think it's a brilliant thing. Now, again, with any new recommendation, it takes many, many years to um, sort of catch up. So it's important when you go back to your clinics, this is something that you can offer your patients. Of course, you're going to offer, you're going to harp the COVID vaccine, patients have to get it, and of course the influenza and the 19 other million vaccines that has prolonged life on this planet. But really, hepatitis B vaccination should be part of the discussion as well. So preventing hepatitis B, again, this is important when I do see somebody with hepatitis B in the clinic or hospital. Yes, of course, they may have hepatitis B, or you're going to work them up to find out more in terms of treatment. But what else is told to them is equally important. Have their family members been tested? Who else lives at home? Are they sexually active? All these things, including avoiding sharing their personal items like toothbrushes, razors, needles, things like that. These are all very important because if they have family members living with them and they're not vaccinated, this is one way that the virus can be transmitted. So it's important what they should try to avoid. But then it's also important to tell them that, if they have children with hepatitis B, that they can participate in contact sports. And there's, this is not one of those taboo things that they have to sort of separate from society. They can go to daycare, they can, have share food and utensils, and it's okay to kiss, um, you know, people with hepatitis B. But again, if until you educate your patients and their family members, they're not going to know. They're going to think of the worst case scenario. And unfortunately, this is true in certain populations that have been studied with hepatitis B, um, especially from the West African. There's a data from the West African where there's this belief that if you have hepatitis B, you should live in shame, or you should, you can't even sit at the same dinner table and have a meal with your loved ones. So this really impacts patients psychologically. Screening and diagnosis, mentioned some of this already. I'm just going to go to the next screen just to make my point. So if someone has surface antigen positive, they have the acute or chronic infection. If they are not symptomatic, most likely it is chronic infection, and you you want to send them for link them to care. For at that point, you check out a viral load, the DNA, and check an ultrasound looking for cancer and things like that. So very important. Somebody with surface antigen positive, you want to link them to care. Acute infection, they obviously symptomatic, they're either in the hospital, or if they don't have really exaggerated, these are patients you want to follow to either send them to an expert who take care of them, or you follow them to see whether they can clear the virus or not. Sometimes it can take weeks to months, but they still need to be linked to care, but they don't need to be started on treatment unless they're getting worse, and that's a separate discussion. But at that point, they will be in the hospital. If they, in part of their screening strategies, they only have a surface antibody and a core antibody, they had the infection at some point. Maybe they come from a high endemic area. Either way, they are fine. They don't have the disease right now. The only thing you need to tell them is that if they ever undergo chemotherapy or any kind of heavy immunosuppression, they can reactivate this virus because the virus does leave its circular DNA embedded in the host genome, and at that point it can reactivate itself under heavy immunosuppression. So it's something they need to remember. If they only have the surface antibody and none of the other two, well, they were vaccinated at one point and they're great, wonderful. If all the three serologies are negative, well, guess what? An opportunity to vaccinate them. And again, if they have a poor antibody only, depending on, it could be a false positive, it could be a remote infection. Again, it depends on what's going on. If they're HIV, you can even consider giving them a vaccination at this point. There's some data behind that. But again, this is not that frequent in trying to figure out what it is. So it's unless it's a special population, severely immunocompromised, HIV, that kind of thing. Okay. Very important, there's more and more awareness about hepatitis B and the Delta virus. Again, Delta virus is a handicapped virus that cannot reproduce on its own, so it needs the help of essentially the help of surface antigen to go through its life cycle. So at the first opportunity of identifying somebody with hepatitis B, it's important to check the hepatitis D serologies. And if the serologies come back positive, then you should check for the viral load. It used to be a sort of a forgotten virus because it's sort of, it's only, at least the awareness was only in certain parts of the world, but that's just because I think there wasn't enough testing. Now that we're doing more testing, we're finding more and more of these patients. And although what we can only offer them right now is interferon, there are drugs that are being developed, and one that's actually available in Europe, but hopefully will get licensed in the United States soon, that will be available if you have patients with the Delta virus. HIV, often these viruses go in pairs. So if they have HIV or hepatitis C, an important time to check for hepatitis B because there are certain treatment implications that you need to be aware of if they have B and C at the same time. And certainly HIV, because that can, the ID expert can tailor the HIV regimen to cover hepatitis B as well, although most of them do cover hepatitis B. So I'm just gonna, high risk groups for Hep B screening. The immunosuppressive patients getting immunosuppressive therapy. So the rheumatologists and the oncologists and the transplant folks always are checking for hepatitis B because any of the drugs that these groups provide can make the patients with a poor positive or surface antigen positive with silent disease, they can get a severe flare and even go into fulminant hepatic failure. So it's very important that these serologies be checked before and addressed before they get any of those immunosuppressive therapies. End-stage liver disease, they get yearly testing. Very many of them are poor responders to vaccination, but if they have not received the vaccination or have not responded to the vaccination, they need yearly screening because of the obviously high risk situation they're in hemodialysis. And of course, the others are pretty straightforward. I'm going to just jump a couple of more because I'm not going to get to the end of this. Something it's important to remember that we have to think about in any medical illness that you are treating, there are always certain risk factors which we all know about. When you see a diabetic patient, of course you know what to do. I don't treat diabetes anymore, but you're looking at that patient globally. You're not just looking at the hemoglobin A1C. You're making sure see an ophthalmologist. You make sure that the circulation is intact, because wherever the glucose goes, that's where the problem is. So make sure they don't have coronary artery disease, things like that. So I think with the hepatitis B patient also, or looking for hepatitis B, it's you want to sort of focus on the risk factors, country of origin, country of birth, sexual partners, family history. These are all very important questions to be asked. So what are the treatments that are available? Well, first of all, does treatment work? Well, treatment does work, otherwise we wouldn't be talking about it. But this is a study from a few years ago that just looked at a prospective group of hepatitis B patients with a cirrhosis and with decompensation. They just were followed on treatment. And essentially, majority of them were lamivudine, which we kind of don't use in this country anymore. It was the first line treatment that came out a few years ago, but it had a lot of challenges with resistance. But lamivudine, if you look at this graph on the right, basically, you look at the responders, meaning after starting them on treatment, their viral load decreased to becoming undetectable. And you see the three groups: responders, non-responders, and untreated. You could see that when you look at over time of a few years and their survival, the people who responded had the best survival, which means that when you put somebody on treatment, one of the goals that you're looking for that you can follow every few weeks when you do the blood test is their viral load. As long as they're taking the drug and there's no drug-drug interaction and they're tolerating the drugs work. Collectively, they work. We can talk about which one's better, which one's worse, that and that. But if they're taking the antiviral, then you have to take the virus, the compliance has to be stressed highly. These patients do better over time. And this is sort of a similar curve showing that the people who respond to treatment have better survival, transplant-free survival. So before you, in a pre-treatment evaluation, there's really nothing special, except a lot of the questions that we've already gone over. Those are what you're sort of thinking about, which is what are the risk factors for viral hepatitis? Is this somebody who comes from a country of origin where this is a big problem, like the prevalence is very high, or they have a history of IV drug use? And, along that, are you thinking about just hepatitis B, even though you're going to check them for HIV and hepatitis C, or the likelihood of the other two viruses is extremely low based on their risk factors? Again, how long they've had the infection for? The longer they've had that for, guess what? The longer we're thinking that they may be at risk for having advanced fibrosis and cancer. So these, and of course, family history is very, very important, because if they have any risk, any cancer, liver cancer in the family, it's important to have a very, very low threshold to start them on treatment for their chronic hepatitis. The goals are, yes, you want to get them viral load undetectable because the antivirals work, but it actually improves the histology. And currently, the best case scenario, you get them undetectable. Very low likelihood that you're going to get a functional cure, because the meds are just not that great right now, where you lose the surface antigen happens a handful of times a year, not very common. What we're looking for in the next 10 years, hopefully, or less time, is drugs that are being developed right now, where you get a complete cure, meaning you not only get rid of the surface antigen, but you lose that circular DNA that's embedded in the genome, which has no chance of replicating under immunosuppressive states. So these are the drugs that are available. I could tell you that the ones that are used very common are tenofovir and entecavir, and they work. Tenofovir has no known resistance associated with it. Entecavir, there is some, but essentially it's really they're well-tolerated drugs. Here are the guidelines. We could skip the specifics, but you're looking because everybody has a cell phone and you can go on UpToDate or any of the guidelines and look them up. So basically, in order for you to put somebody on treatment, because this treatment is going to be a very long time. This is not like take 2 in the morning and call me. This is going to be for many, many years. So therefore, you want to make sure that they have elevation of their liver tests, and not just one value, several. They have in the E antigen positive status, they're going to have higher viral load, and in the E antigen negative, they're going to have the threshold is different. But if they fit this bucket, you should treat them. And in the patients with ALT less than 2 times upper limit of normal, you're sort of looking for more information. This is where FibroScan plus minus a liver biopsy helps you make the decision. Again, you're looking for all this information in a certain timeline. You don't have to make the decision over one visit. If they're cirrhotic and their surface antigen positive, they need to be undetectable, and that's very important. So I'm just gonna go over a few more slides because I know a few presidents are gonna cut me off. So I mentioned earlier that your viral load decreases with antiviral treatment, but up until a few years ago, we didn't believe that cirrhosis can be reversed. And this study, one of several, showed that, where they had a few hundred patients in this study where they time 0 did a biopsy, and then they did a paired biopsy on half of these patients. Not everybody agreed to a second biopsy at 5 years. And they were able to show, if you just look at the red area, the red is the high cirrhosis patients. Cirrhosis actually decreased in year 1 and year 5 when these patients were treated with the antiviral. And there was so again, we do believe that there are significant benefits to treatment. Let's talk about this last thing and then I'm going to stop. So basically, New York City Department of Health initiative, and of course the national initiative, has really provided excellent care for the time where the pregnant mom shows up to the OB for that initial visit, and the OB is mandated to check the surface antigen. And many of these patients, that's the first time they find out that they have hepatitis B. Again, a great opportunity for the OB to link these patients to care. Surface antigen is positive. How do you handle it during pregnancy? Well, you have to follow them. And the goal is to check the viral load almost every trimester. But by 28 weeks, if the viral load is 10 to the 6th copies, this is not an exact number. You could be close to this number and have a discussion with a to-be mom. But if that number is at that point, you can start. In fact, the starting treatment at the 3rd trimester with tenofovir, which is a safe drug for pregnancy, reduces the risk for transmission. But on top of that, the infant also gets HPV and vaccination at birth, as opposed to if they're less than that number, then you can consider not starting treatment. So this is important. So what I'll do is I'll stop here and take any questions, and certainly, sorry I had to rush through some slides, but I was limited on time.
So yeah, if you have any questions, you can just unmute yourselves or put it in the chat as well. I can keep an eye on that.
Hi, Dr. Kalia. Thank you so much for this nice presentation. I just have one question regarding patients with isolated core antibody positive test. I had like a patient on the clinic, and the patient was having core antibody positive. So I repeated his hepatitis serology 6 months after, and it was showing the same. Like I was expecting, okay, maybe we are in the window period, maybe it's acute infection and we still doesn't have the surface antibody in there, or he's immune and he have a weak immune response. So I don't know how you interpret this. I know it's like 1 from 4, but now giving persistence of isolated core antibody. So what do you think?
Almost like every 3 months, I get a question like this, a clinical question like this. Either a colleague calls me and says, what do I do? So the way I handle it is I think of like, let me first rule out, is this an extreme case scenario? Which is something I didn't talk about is occult Hep B, which is they have a negative surface antigen, but they still have a low viral load in their system. So again, everything starts with history, right? What are the risk factors for presence or absence of risk factors for hepatitis B? Country of birth, sexual practices, drug use, tattoos, all that stuff. If that all comes out negative, and the core is obviously, you checked it a few times, the core is so positive, and they don't have HIV, and they the viral load is also negative. At this point, and I'll do one more thing. I will check 2 different labs. So if they go to lab 4, I'll have them check it at request, or another like a lab. Sometimes you can decipher if it's a false positive or not that way, because they use sometimes different assays to determine. If doing that investigation, it comes back as positive, I'll just worst case scenario, you were exposed and you're done, right? Because the majority of people, you can figure out what their risk factors are, but some don't. Like, what if they had a roommate in college who had hepatitis B, and you know, there was blood on the floor and they cleaned it, and that's how, you know, they had a enteric illness, they didn't report it, maybe they thought they had hepatitis A. You know, you can kind of think of scenarios where people just don't go into the hospital when they're sick because they're like, I'm young enough, I can deal with this at home. So you could say it's core positive, you were exposed, nothing to do, just if you ever get, God forbid, chemotherapy or immunosuppression, your doctor has to put you on prophylaxis, right? But if it's HIV, or if they had any kind of, you know, if HIV situation or any other immunosuppressed situation, I would actually, there's data, you can actually try to vaccinate them to see.
Okay, so
That I think,
yeah.
So false positive, exposed, or occult Hep B are 3 potential scenarios. You have to do a little bit more digging around to fit them into one of those 3 buckets. Is that the question?
Yeah, thank you.
Of course.
There's a question in the chat about Hep C reactivation.
So with the new DAAs, the direct antiviral agents, there's been a black box warning of hepatitis B reactivation in patients with surface antigen positive and core positive. So there are different strategies to address that. But first of all, I've never seen it, but that doesn't mean it doesn't happen. It just means that you have to be aware. So patients get their serologies checked before hepatitis C. Treatment is initiated. If they're core positive only and surface antigen negative, I check their labs monthly on the direct antiviral agent. If any of the liver tests go up, or they bilirubin anything, then I check the viral load for hepatitis B and I start them on treatment. So that's one. If they're surface antigen positive, I separately, you know, evaluate them. Do they meet criteria for treatment for hepatitis B? And it's not very common, but I have a handful of patients over the years who I start them on Hep B treatment first, and once they tolerate that and there's no drug-drug interaction with the new DAA that I'm going to give them, I start them on Hep C treatment. So either way, it's because it's a black box warning, you should follow it for the course of the 3-month or 8-week course of DAA treatment if they fall positive or circumstantial positive. Look at that, I finished on time.
I know we're at time, so I will send an email and with a PDF of the slides and a brief evaluation, if you guys don't mind taking a minute to complete that. And with the slides, there are also some hepatitis B clinical resources for all of you. So thank you so much for having us. I really appreciate it.
Oh, thank you so much for being here and taking the time to show us, not just teach us about hepatitis, but actually show us our data. I think it was very important for us to see. So I see Dr. Rugwani is already here. Thank you so much for joining us as well.